Hello friends, today I want to describe you one more time our technique, Istanbul Varicocelectomy technique, what we do and how we do with this technique. So first of all, let me show you how we start the technique, and let me show you what varicocele is. Okay, as we told many times, varicocele is the enlargement, abnormal enlargement of the testicular veins. It is more common in left side, as we know, because of the anatomical difference of the left testicular vein. And when these veins swell, they heat up the testicle and decrease the sperm quality. So we have to fight with three different kind of veins in varicocele surgery. First, and the main part, is internal spermatic veins. They come from the, of course, all of them originate from testis, and they drain into renal vein and to main venous stream, and they are the main drainage system of the testicle. These are internal spermatic veins. There is an external spermatic vein, or it may be 2 or 3 in number, so external spermatic vein group, and another vein group is gubernacular vein group. So all these three veins are affecting the varicocele. So the treatment of varicocele mainly consists of interventional radiology treatment like embolization, or a surgical treatment like the microscopic surgery of the varicocele disease. What is defined till now and accepted all over the world, the microscopic technique is the best technique to treat the varicocele. What we do in microscopic technique is, as we see here, with microscopic focusing and microscopic view, we try to save the artery and nerves and the lymphatics and cut all the veins, ligate the veins in both ends, and cut the all venous structures in between. And also here we have the external spermatic vein, so we can ligate this. This is what we are told in our education, and all the urology doctors are doing this in that way. Then some other technique defined, like delivery of the testis from the incision, and by this way all the internal veins are treated and external vein is ligated and the gubernacular veins are treated. Is this necessary? Yeah, this is an ongoing discussion in the urology world. So because of the in connection of the gubernacular veins with the external veins, and sometimes all of these three structures all together, it is recommended in some centers to ligate the gubernacular and external veins and the internal veins all together, but in some other centers they conclude that there is no difference between delivering the testis or not, but in our clinic we want to deliver the testis. Okay, so the main difference of our technique from the others are, we started to remove the external spermatic vein, because you have two options, like here you can just ligate and cut in between, or like here you can take out a segment of this external spermatic vein. We choose to do it like this because sometimes when when we leave the vein behind, just ligated, the connection of it with the gubernacular veins, other veins, may make the blood flow continue, and this makes the disappearing of the vessel impossible. So we want to get rid of these veins as long as we can. So the first step of our procedure is taking out the external spermatic veins. So why we started to do this, deliver the testis, excise, take out the external spermatic vein and gubernacular vein? Because previously, after the operations, when I'm doing control with my Doppler ultrasonography device, I was noticing that the blood flow inside the ligated veins were continuing in some patients. Let me draw it like this. There is a vein and we ligated here both ends and cut in between. So we hope that the blood flow inside this part will stop and it will coagulate and this vein will be absorbed by the body. But after the operation, immediately 1 week for example after the operation, when I do the control, I noticed that there is still, I was expecting coagulums inside this vein, but no, in some of the patients, I can say most of them, the blood flow was continuing. There was blood flow. So I was shocked. I couldn't understand why it's happening because this is ligated. I was sure this is ligated here. So I make a theory. I think what's happening is there are some little tiny branches here in these vessels, very small, that are not visible during the procedure. So the blood coming from the testis side is finding some route from these channels, branches, so it continues to flow. When it flows, it will not coagulate and it will not disappear. So this is happening in at least 70% of the patients. So it's cured in 70%, but 30% of the patients, the vein stays there. So I wanted to change the procedure and I concluded excising this vein will help the patient more, because during the operation we take out a long segment and this is disappeared immediately throughout the operation. Of course, in the testicular part, close to testicle, there are many branches of this vein and all of them contains their arteries next to each other. So we can take out a very big segment of this vein. So usually we take the pictures as a long segment of these veins, but near the testicle at some point we have to stop, because we can't take out these vessels, we can't go inside testis. Testis has a sheet around here and you can't enter to this place. So even after the operation, the patients can feel some of the branches here near the testicle, but we are leaving only that part for self-disappearing, not all this long part, and the success rate is really different and very high compared to normal conventional ligation of this vein here, and hoping this vein will disappear by itself. As I said, in 30% of the patients it is not disappearing because of the branches that enables the flow to be continuous. So after I begin to remove the external spermatic and the gubernacular veins, I was doing the internal part as in conventional procedure, like ligating two ends and cutting in between. Then I noticed that still after the surgery you can see these veins, and it takes too much time for the remaining ends to disappear. So I said, why not also try to get rid of these veins during the operation. So I wanted to take out long segments from these veins too, and I started to dissect these veins as long as possible. So the second part of our technique is, okay, so these are the schematic view of the internal spermatic veins. So the veins have some connections in between. So consider this as a 3 millimeter, this is a 4 millimeter vein, and this is in between a 1 millimeter little tiny branch, and you can miss this branch easily. So when in normal operation, conventional procedure, you make a ligation here, and just like this, you ligated this line, then ligated here. So you cut the vein and also made the same thing here. But you usually scare to cut this because it's very tiny, very thin, and next to it there may be an artery. So people usually leave these little tiny veins and they remain. So when they remain, the blood coming from here and stopping because of the ligation and expected to make a coagulum and disappear, sometimes finds a route from here and it continues. So this part is not coagulated and not disappeared. Same thing happens in that vein. It finds a route from here and the blood flow continues. And by time, this vein is enlarged too because of the too much venous flow from here. Or even if it is not get larger, these remaining parts still seem like a varicocele, act like a varicocele, so we call it recurrence. Actually, I believe it's not recurrence, but persistence of the veins. So, I believe if you also cut this vein, the operation will be successful. If you cut all the veins, but still, the venous flow can find some way from the in external spermatic or gubernacular veins. So if the blood flow continues here, these veins will remain and they will the effects of the bad effects of them will continue. So what I want to do to remove all these veins as much as possible. So we leave nothing. For the small veins, sometimes we still don't want to touch them because if the diameter of the vein is normal, it can, like in the right side, which is usually normal, it can make the blood drainage from the testicle without any problems. So we cut and take out the long segments also in the internal spermatic veins. So this is the second step of our technique. And the third and the fourth steps of our technique is easy. It is the using of microscope, microscope, and the third is microvascular Doppler device. This device is important because in the tiny vessels, very tiny vessels, the arteries and veins are come together, and the microscope usually doesn't show exactly which is artery, which is vein. And in that part, you can use the microvascular Doppler to differentiate the artery and vein. It gives a special sound, a different sound for the artery and different sound for the vein. So with these four steps, we call it Istanbul Varicocelectomy technique, and I believe it's really working well. We are happy with the results, and we usually do, unfortunately, recurrent cases. People do not make too much search before the first operation, but if they have recurrence, they look internet for it and they find us. So we are very experienced in the recurrent varicocele surgery. I wish everyone a healthy and good life without varicocele or getting rid of their veins as quick as possible.